Analytics webinar. My name is Mike Saperstein, Marketing Manager with the Spectrumetics team. Before we begin the webinar, I just want to cover a few housekeeping items. At the end of the webinar, there'll be a brief Q&A session. Feel free to enter your questions into the webinar control panel anytime during the presentation, and we will answer them at the end. Additionally, we will take a short break during the presentation for a poll question. Please take the time to answer this, as it helps us refine our webinars and provide even more meaningful content in the future. At the end of the webinar, we will send each attendee a follow-up email containing highlights from the presentation. First, I'd like to introduce our two panelists for today. First, we have Dr. Elizabeth Wolf, the Senior VP of Care Transformation, Quality, and IT for the Richmond University Medical Center, which is a co-lead provider of the Staten Island Performing Provider System. Secondly, we have Dr. Raj Lakhanpal, Chief Executive Officer of Spectrumetics. He is also a member of the HIMSS Clinical and Business Intelligence Committee. Next, just a quick review of the agenda. We'll first review the RUMC Clinical and Business Intelligence Objectives and Challenges. Then we'll go into hospital operations and analytics. Third, improving care of DSRIP subpopulations. And finally, our question and answer session. So without further delay, I'd like to introduce Dr. Wolf.
Hi, thank you very much, Mike. So first, I just wanted to give you an overview of Richmond University Medical Center. So first, we are a hospital on the northern part of Staten Island, which is where the majority of the Medicaid population of Staten Island is. We are an affiliate of Mount Sinai Hospital and their medical school. And we have about 470 licensed beds, about 300 or so occupied on any given day. We have two campuses. One is really the main campus, and then we have another small satellite campus that houses some behavioral health. And I think really our challenge for us is we have three separate electronic health records, which certainly is pretty common out there. So we have Meditech in the hospital, we have eClinicalWorks in our ambulatory sites, and then we have EDIMS, which is a proprietary EHR with the ED department that we subcontract with. Next slide. So certainly, I've joined RUMC about 1.5 years ago, and there certainly was a great need to pull data from all those different sources and really help us better manage the hospital operations. And around that time, DSRIP was just starting up, so we really needed some actionable reports. So really, as we were going forward, we recognized that we needed an enterprise data warehouse to pull data from all of these different and disparate EHRs, and to provide the data analysis that we needed, both at high level, dashboard levels, and also very actionable reports. And we're facing several challenges that many hospitals are. So we're really looking at how can we have actionable reports to look at our hospital-acquired conditions and infections, preventing readmissions, improving our length of stay, and then really all of these being able to drill down at the patient level to make it actionable for the frontline staff. So really what our challenge has been is that data historically has been numerous formats from different data sources. So it's really pretty chaotic to try to pull all of this together. Similarly, we have a very lean IT staff, so they are often overwhelmed by report requests. And sometimes the people requesting the reports didn't always know that we had already built that or something very similar. And sometimes by the time that they were able to develop their reports, the needs had already changed. It was an outdated request by then. And then often just the format it came in just wasn't very visually appealing, and it wasn't easy to really digest. So I think we have an example of that in the next slide. So these are the these are the reports we've previously had for patients with a long length of stay. So a little cumbersome, a little hard to read, and no really good summary. Next slide. So then what we were able to build with SpectraMedics is that it's pulling data from many different sources. Those at the bottom of the slide, you'll see the first three cylinders are our electronic health records data. We're also pulling in survey data. We contract with Press Ganey for patient satisfaction, and it's pulling billing data directly from our EHRs, and that all goes into the data warehouse. Next slide, please. Okay. So we'll drill down a little bit more at the hospital operations. So once all of that data is in the data warehouse, SpectraMedics has built some great analyses so that we're able to really look at, really a lot of our problem areas. So we're able to risk stratify patients using a modified LACE tool, which will help with our readmissions. We have a risk-adjusted length of stay, and I'll speak about that in a little bit more detail. There are numerous population health initiatives with DSRIP, and we also have an accountable care organization. We are tracking the hospital-acquired conditions and infections, and we're even able to we're just in the process of finalizing some provider, essentially report cards, so we can really give the providers the feedback on how they're doing with length of stay, and we'll have an example in a moment. Next slide. So really what the senior team really needed, as we said, high-level dashboards to get a summary of where we're doing, of how we're doing, and then again being able to drill down to the level of the units and the patients, and sometimes we sort by payer, so really some live actionable dashboards that the frontline team can use. And this is updated every day, so it accurately reflects exactly who is in the hospital. I had mentioned previously the risk-adjusted length of stay reports, and we also are highlighting where we're falling short on the core measures. So anywhere where we're below thresholds, those are the reports that I'm sharing with our management team on a regular basis. And then it's been great to be able to always compare not only just how we're doing, but what are those state and national benchmarks, be they hospital compare or the Joint Commission with, where are we striving to go? So it's always a good comparison for us. And then I mentioned the report cards for the physicians, and we can even aggregate that to the physician group on some key metrics. Next slide. So one of our big challenges has been our readmissions, where we have really been struggling with that as a hospital. So what's really been what's been extremely helpful is using SpectraMedics has modified the risk stratification tool of LACE to really help identify who is at risk for readmissions. And then we can actually look at the patient census on any floor, and based on that criteria, we can tell if they are at low, medium, high, or very high risk of readmissions. Next slide, please. So this is actually a summary of how, using this risk tool, how successful we have been at predicting readmissions. So you'll see there are two graphs here that's using 2014 data, and then to the right 2015 data. And then based on this tool, if you look at the x-axis, the tool predicted whether they were at low, medium, high, or very high risk of readmission. And then the y-axis says with that cohort of patients, what percentage of those patients were actually readmitted. So it very accurately predicts who's at highest risk. And you'll notice that then there's really like the vast majority of the readmissions are in the high and the very high risk category. And I think they're about 8 times as likely to be readmitted if they're in one of those two categories, high or very high. Next slide, please. What we've also found to be very powerful is, so the value-based purchasing is something that SpectrumMedics created for us, and we present this quarterly when we update the core measures, and there is even a drill down for patient experience level data that we show every month. So we're getting this in front of our board quality team, in front of our senior management team, and the senior leaders across the hospital, so they can really understand how quality aligns with finances. So I'm guessing that a lot of you are familiar with value-based purchasing, and this is not our hospital data, but just some example data. So it breaks down the various value-based payment domains. I really like at the bottom of the slide where it really highlights colorfully what the holdback has been from CMS, because we know that they hold back 2%, and then based on our performance in these different areas, we're able to earn back that amount. So we have found these graphs of how much is, basically how much we're leaving on the table to be very powerful in communicating opportunities we have to have more revenue from CMS and improve quality. Next slide. Similarly, this is a physician level, this is an example of a physician level, essentially report card. So it's good to know, you'll see the 3 bar graphs for each specific physician. So one, the number of discharges. So we sorted by that, so we really know who on top with the high volume, who is really driving our readmission rate and length of stay, just by sheer volume. And then we look at the readmission rates at the level of the provider, so we know that gives us a sense of either who's not communicating with the PCP as well, or sometimes we have a large voluntary staff, so it might be the same person rounding them on them in the hospital who follows up with them, and what is their readmission rate, because that's certainly affecting us with the CMS readmission penalty. And then the length of stay, like many hospitals, we're struggling to be more efficient and reduce length of stay. So it's really the physician level, and that's been very helpful for us to go to specific practices who admit a lot and share that with them, this data, and as we continue our dialogue with how we can shorten the length of stay. And I should also say that, just at the last slide, is that we're presenting this also in our physician lounge. So this is really in the theme of transparency. We're sharing that in the lounge so people are aware. And then, as we invest in SpectrumMedics, we certainly need to think about what are our ROIs. So certainly a big issue for us is reducing the length of stay. Again, with the provider report cards is really key. And we're actually, it's very exciting that we have, we need to build something on our end, but we'll be able to pull in concurrent coding to the reports, so that when we look at a unit level report for all the patients on that floor, there'll be concurrent coding, so we'll know what their predicted length of stay is. So when we have interdisciplinary rounds, that'll be part of the conversation of, like, their expected length of stay is 3. Today is day 3. What's happening? And then certainly the risk stratification can be helpful for length of stay too. Excuse me. With the bar graphs, we saw that identifying patients at high risk for readmissions has been very helpful, and we're about to go live with a program for transitions of care, in which we're actually contracting. Rather than build it ourselves, we're contracting with an external agency that's been very successful with this. And based on the risk stratification that SpectrumMedics has calculated for us, that's helping us to identify those patients at high risk for readmissions, and they'll be doing transition of care services, really health coaching, and the patients are working with is purely based on the risk stratification from the data warehouse. And along with this, obviously, it helps with us improving the discharge planning, and certainly aligning the resources to give them most of those at highest risk for coming back. Another opportunity is to to prevent hospital-acquired conditions. So we have found that when we quantify the amount of money at risk and how much we have left on the table with various hospital-acquired conditions, that's helping us drive where we're emphasizing in the surgical site infections or CLABSIs or CAUTIs to really be able to drill down on those quality of care issues that affect us financially. And then, as I mentioned with the value-based purchasing, certainly the patient satisfaction scores we update every month when they're updated from our vendor, and the patient safety indicators that I previously mentioned. Next slide.
Thank you very much, Dr. Wolf. Now we'd like to take a short break for everybody. We have our poll question. Which of the following is your biggest area of concern? The choices are your high rate of readmissions and penalty, monitoring and improving value-based purchasing performance, reducing HAC and HAI tracking effort, or physician performance benchmarking. Take a few minutes to answer the question and we'll be right back. Thanks. Thanks, everybody. It looks like the biggest concern is high rate of readmissions and penalty. Now I'd like to turn the presentation over to Dr. Lockenpaul.
Thank you, Mike. And thank you, Dr. Wolf. Hi, this is Raj Lockenpaul, and it's my pleasure to present to you. How do I move this slide forward? Okay, thank you. So RUMC is Richmond University Medical Center. RUMC is the short term we use for them. Their role, they're part of the Staten Island PPS. Staten Island PPS is, for our audience that's outside from New York State has 25 PPSs. PPS stands for Performing Provider Systems. And PPSs generally have a lead or a co-lead provider. And except for a few of them, most of them are health systems or hospitals. So RUMC and Staten Island University Hospital are two hospitals in Staten Island that are co-lead providers. So RUMC's role within SIPPS is that they have been instrumental in providing clinical data and billing data to help SIPPS build near-time analytics. And they've also been, because they're one of the two hospitals, all the utilization that happens there, for example, admits to the ED or admits to the hospital, become critical for other partners to understand what the utilization patterns are. RUMC also has a utilization history in the past for all the other partners, which is also very important as we progress within DSRIP. So this is how Spectrumetics is helping RUMC with their business intelligence for DSRIP. Dr. Wolf had mentioned about the report cards for provider report cards. Very similar to that, we're also building out ambulatory physician report cards as well. DSRIP patient flagging, we're doing that through our EDW. And let me give you an example of that. So for example, one of the projects that Staten Island PPS is doing is, and then RUMC is doing as well, is identifying diabetes at-risk patients. So what we do in that case is, obviously all the DSRIP patients are flagged, but then we run a predictive algorithm to find out which patients are more likely to have diabetes and maybe being missed for interventions. And those patients, those alert flags are then sent to the patient-centered medical home, PCMH. So that's how DSRIP patient flagging, especially as they relate to projects, is taking place. Population health, we talked a lot about that. The biggest part of that is risk stratification, and then we'll talk more about other population health initiatives as well. And then actively engaged patients. So this is a new concept. This is a concept I want to explain. That actively engaged means that partners have put in an active intervention for that patient. So one is they've identified the patient, and then they have somehow actively engaged with that patient. And from Rumsey's example again, care transitions is a project that they've adopted. Within that, an actively engaged patient will have teach back, will have medication reconciliation, an appointment will be made within 3 to 7 days post-discharge. So then we now have that patient as actively engaged. Gaps in care, doing a lot of work around gaps in care and disease registries. The other concept is superutilizers. Superutilizers are those that have more than six or more ED visits, emergency department visits in a year, and 3 or more inpatient visits in a year. So those are superutilizers. Risk stratification, we're following the HCC model for population health and the modified LACE for readmissions, risk of readmissions in the hospital. Let me take either one of them. Spectromedics has enhanced that with clinical data, with behavioral health data, and social determinants of health data with some text mining, natural language processing capabilities to make those models much more robust. And Dr. Wolf had demonstrated those results to you. And I talked of PCP alerts as they relate to diabetes at risk and other conditions. And obviously, the EDW has a longitudinal patient record and has the patient history in it. So how's Rumsey using Spectromedics tool at this time? Obviously, identifying patients at high risk for admissions or readmissions is one thing, is a main driver, and Dr. Wolf had outlined all the areas that they're using it, value-based purchasing and other, looking at reducing HAC, HAI scores. But as it relates to DSRIP, identifying patients, the goal of DSRIP New York is to reduce preventable hospital use by 25% over the next 5 years. Now 3.5 years are left. And then also integrating clinical and behavioral health. So as most of you on the webinar know, that behavioral health plays a very, very big role in readmissions and admissions and non-compliance, so that we're integrating clinical and behavioral health. Rumsey has a big behavioral health center too, so we're integrating the two visits. Improving population health, integrating DSRIP actively engaged patients into the Rumsey data warehouse, so that as we find out that this patient's actively engaged and they come to the hospital, a message is sent to the, or provider is notified that the partner, other partners outside the hospital are notified that those patients were seen in the hospital. And obviously, DSRIP year 2, we're in the middle of DSRIP year 2, it is transitioning to pay for performance as opposed to pay for reporting. So that becomes very important. Value-based purchasing scores become very important as we advance in the DSRIP years. Population health, obviously we integrate clinical data, adherence data. Adherence could be medication compliance, could be adherence to care plans, utilization data, I talked about that, financial satisfaction data, and then operational data. Operational data could be modifying workflows or sending alerts. So, and at a high level, our approach is we built out disease registries. And this may not be totally relevant to Rumsey, it's maybe more relevant to Staten Island PPS. So hot spotting to identify disease patterns, identify performance opportunities, and then I talked of predictive modeling. a lot of work with engaging community-based organizations, engaging groups outside the hospital as well, for us to find out how to improve the care of actively engaged patients and managed care organizations too. And here are some of the projects that Staten Island has, PPS has taken, and some RUMC has taken as well. Diabetes is a big one for both SIPPS and RUMC. Obesity, chronic alcohol abuse is another big one. Behavioral health is a big one. Opioid use is there too. And then cancer, hypertension, and asthma are not as critical to them as the other ones I mentioned. And here are some of the projects and the disease registries we've built, and these may be specific to the SIPPS and RUMC projects, but there are other disease registries we have as well. I believe we have 35 disease registries right now. Health home at risk, this is integration of, again, primary care and behavioral health, chronic disease and behavioral health, diabetes management I talked about, care transitions I briefly touched, so that's a big project for both SIPPS and RUMC to reduce 30-day readmissions, integration of palliative care into nursing homes, and then Interact. Interact is admission from a skilled nursing facility to the hospital, so reducing admissions and readmissions from skilled nursing facilities. And this is an important slide. I'll take a minute to explain it. At the present time, we're not doing a lot of work on this slide with RUMC, but this is a core competency of the organization as it relates to DSRIP, and we're providing this service to all our DSRIP clients. So this is about project measures, where New York State Department of Health provides measures on an annual basis, measure results. For example, Staten Island PPS tracks about in the 70 to 80 range the measures, which are retrospective in nature, based on adjudicated claims data from the Department of Health. And we received, or SIPPS received data about a month and a half, 2 months back, which was retrospective by about a year. What we've done with RUMC's help as their co-lead provider, we have taken in claims, taken in clinical data from their Meditech EMR, from their eClinicalWorks EMR, as well as the EDIMS EMR, taken in that data, so that becomes very near real time. We get a nightly feed from Meditech and eClinicalWorks. We take that data. We also get billing data, 837Ps. So now we have data assets that are much more real time. And with those, we calculate the measures. Right now, we're calculating them every month. Our goal is to get them to every 2 weeks or every once a week. Within the measures, there are pay-for-performance measures, and then there are high-performance measures. So our goal is to make it as recent as possible or as current as possible with those measures. And there's a very innovative concept that I personally, as a physician, really like, and that is, it's called high-impact patients, or we calling them, for simplicity's sake, the top 500 patients. So these are patients that have failed 5 or more measures, and these could be top 500, could be top 1,000, and we are beginning to track them on a regular basis so that we can then improve their care rapidly. And these are high-impact patients because these are all pay-for-performance measures, and improving the care will not only allow the PPS to provide much better performance, but will also enable them to receive the greatest amount of incentives for themselves and their partners. Oh, I'm sorry, and this is, Dr. Wolf, this is your slide.
Hi, thank you, Raj. So with the functionality of Spectrumetics, again, just to highlight some of the things we've spoken about, this is a fabulous tool, if I do say so myself, to help reduce readmissions and unnecessary hospitalizations. It's really helping us drive performance with the PPS, which is also just high quality patient care anyway. So it's nice that district aligns with other quality patient care. Understanding with the PPS and the metrics, where are those opportunities, where are those missed opportunities, so we can work to close those gaps. It's really at the level of the patient. It's very actionable data. And then this is going to be positioning us well as certainly as Medicaid and other payers move to value-based purchasing. This positions us well in making that transition. Next slide. So working with Spectrumetics has been helpful to us in managing the risk and really giving actionable data and empowering the care teams to use data that previously was in disparate systems, and then really transforming that into valuable, actionable data to frontline staff. We spoke about how it enhances our operations and improves the quality of care that we provide. Certainly, with as quality more and more is aligned with financial reimbursement, we are prioritizing some of our quality issues with where the greatest opportunity from a financial perspective is. It helps us better take advantage of the numerous pay-per-performance and other quality-based incentive programs. And most importantly, though I often message this depending on the audience in regards to finance, at the heart of this and most importantly is really how are we improving the clinical quality for the patients and their experience of care at Richmond University Medical Center. Next slide.
Thank you very much, Dr. Wolf. Before we move on, I just wanted to let everybody know that we've actually created a case study along with RUMC, which details a lot of the content that you've actually heard on the webinar. We'd love to send it to you. You can either contact Mark Bryant or visit our website and click on the Media Center link to request a copy. Before we move into the Q&A session, I just wanted to also let everyone know that we'll be doing a webinar on the Medi-Cal Prime program in the beginning of October. This program is a successor to the California DSRIP program, and hospitals within the Prime program face many of the same challenges as New York hospitals and PPSs. This will be a great webinar, so stay tuned and we hope to see you there. Now I'd like to begin the Q&A session. We had a couple of great questions come in. I'm also going to ask Dr. Rajan Kumar, who is our Director of Analytics, to step in and help answer the questions. First question, how does this analytics process include community-based ambulatory and support services that happen in the community which are not internal to the hospital?
So this is Rajan Kumar. I am Director of Analytics at Spectrumetics. So we are getting data from a number of community-based organizations which are partners with Staten Island PPS. And we get data in multiple formats. We get data at different frequencies. And as soon as the data is available to us, we integrate it with we integrate the data with the hospital data and include that in the patient longitudinal patient record. So that data is available to the users and to the downstream providers to improve the care of the attributed population at the PPS.
Thank you, Dr. Kumar. Next question. Can the analysis look at potentially preventable admissions as well as readmissions?
Yes. Preventable readmissions are readmissions which can be prevented by addressing the immediate needs of the patients after discharge. So we have a proxy algorithm that identifies which of the patients are more likely to have readmissions, which should have been prevented or can be prevented by appropriate medical care.
And I can also add that when we look at our readmission data, it is broken down into those what are often described as more ambulatory sensitive conditions, the COPD, the CHF, which also affects us financially, that we can drill down to the level of the diagnosis for that.
Thank you. Next question. How long does it take to implement the solution?
We have standardized the process of taking in the data and implementing the solution. So once we get the data from the client, we can implement the solution in 2 to 4 weeks.
Generally, it takes 8 to 12 weeks. 12 weeks is the right time frame from contract signing to providing productive use of the solution. And then as we advance, so what we do is we understand what data sets are available or data assets are available quickly, what will take time, and then what solution can be provided, what is the low-hanging fruit in terms of solutions that we can implement right away, and what will take time because data is not available.
And our final question, what is the cost model for the analytics package?
So let me take that. The cost varies. We have an initial implementation and pricing, implementation, customization, and then there's a annual licensing fee. It's a SaaS model. The licensing fee is spread over the duration of the contract, which could be anywhere from, which are generally our contracts are 3-year agreements. Thank you.
Thank you, everybody. Thank you, Dr. Wolf, Dr. Lakhanpal, Dr. Kumar. We hope you enjoyed the webinar, and stay tuned for our follow-up coming via email soon. Thank you.
Thank you.